Our next speaker is Dr. Neha Madan, and she's going to be speaking on dry eye associated with anti-glaucoma medications. And this is obviously a very, very important subject as well, because now we have patients who are on 2 or 3 drugs, and they all end up developing dry eye at some point, and it's a dilemma on how to manage their dry eye, and kind of go with the preservative-free drops as well for glaucoma, and which lubricants to use. So I think it will be a useful talk. Thank you.
A very good morning to all. I would like to thank AIOS to allow me to speak on this topic. So I'll be speaking mainly about dry eye associated with anti-glaucoma medications. The objectives of the talk are to define glaucoma therapy related ocular surface disease, discuss the global impact of dry eye and glaucoma, discuss the causes, mechanism of dry eye in patients with anti-glaucoma medications, discuss the signs and symptoms related to it, discuss steps that can be taken to identify ocular surface disorder in glaucoma patient, and understand the current and emerging treatments to decrease intraocular pressure while minimizing toxicity on the ocular surface. Holo et al. Have described glaucoma therapy-related ocular surface disorder as imbalance of the ocular surface homeostasis caused by the toxic effect of chronic topical medication, which leads to tear film instability, epithelial damage, and inflammation. Coming to the prevalence, about 1 in 6 of the patients of glaucoma have dry eye symptoms. In many of the studies, it has been shown that around 40 to 59% of patients of glaucoma have dry eye. Ocular surface disease in patients with glaucoma can manifest as varied presentations like superficial punctate keratitis, tear film instability, dry eye, allergy, pseudopemphigoid, or vortex keratopathy. Now, coming to the causes of ocular surface disorder in glaucoma patients, it could be due to the medical treatment or the surgical treatment. First of all, that glaucoma requires a prolonged treatment as it is a chronic disease. Then the topical glaucoma medications have an active compound and a preservative. The active component causes the direct impact and the preservative causes the indirect impact. The need for multiple medications is required in most of the cases within 2 years of starting the treatment. Then the surgical causes being glaucoma filtering surgeries itself, as they cause conjunctival epithelial damage and cause limbal stem cell deficiency. Then the adjunct procedures like bleb needling can also cause conjunctival epithelial damage and lead to limbal stem cell deficiency. The antimetabolites cause an additive effect to all the above surgical procedures. Then the comorbidities like diabetes and patients who are already having autoimmune pathologies can give an additive effect with the patients who are diagnosed with glaucoma. Then age per se, with age there is loss of acinar cell, loss of goblet cell. So in glaucoma also there is a chronic disease, it also leads to an additive effect. Now coming to the direct impact of the drug, that is like first is prostaglandin analog, they have a higher prevalence and severity of meibomian gland dysfunction. Beta blockers per se act on beta receptors and reduce basal tear turnover rate and reduce the corneal sensation. They cause xerotic alteration in conjunctival epithelium. And then alpha adrenergic agonists have a high incidence of allergy as compared to the other anti-glaucoma medications. Now the indirect impact is because of the preservative. The most common preservative that is used in the glaucoma medications is BAK, benzalkonium chloride, which is an quaternary ammonium compound which has a detergent effect. Its toxicity is mainly related to the number of daily drops that we use and the long duration of treatment. What it does is it disrupts the homeostasis of the tear film and ocular surface. It causes loss of goblet cell, meibomian gland, accessory lacrimal gland. It causes disruption of the corneal epithelium and a reduction in corneal sensitivity, disruption of the tear film and thinning of the mucous aqueous lipid layer, and thus increases inflammation, increases the matrix metalloprotein 9 levels. In a study where an in vivo confocal microscopy study was done, where the effect of long-term anti-glaucoma eye drops was done in conjunctival structures, it was noted that the epithelial cell density, goblet cell density, dendritic cell density, and subepithelial fiber diameter had decreased significantly. Now, as already told that the polytherapy increases the toxic effect of BAK, which has been shown in the ocular hypertension study and CIGHTS study, where polytherapy increases the patient's cumulative exposure to potential toxic components, that is BAK. Other preservative that is used is polyquat, which is also a similar detergent action and causes superficial epithelial damage and reduce conjunctival goblet cells. Now, we can see that BAK has two concepts are there, that is dose dependent toxicity and concentration dependent toxicity. So what should be the upper limit of BAK that is used? There is a study which says that the strongest predictor of ocular surface disease were daily BAK when there were more than 4 topical medications were used or more than 2 anti-glaucoma medications were used. And the other thing is concentration dependent toxicity. The most common drops that we use have a higher concentration of BAK, like Xalate, latanoprost, they have a 0.02%, whereas Timolate, Dorzox have a 0.005, 0.0075. So better it should be shifted to the drugs that have a lesser amount of BAK concentration. So these components increases dry eye, that leads to poor compliance and further leads to glaucoma progression. What are the symptoms that they come with? There can be burning, irritation, itching, tearing, decreased visual acuity. Ocular surface disease can negatively affect the quality of life and compliance with the treatment. Now, how do we evaluate them? Like already told that the dryness can be evaluated in a subjective way and an objective way. The questionnaires have been discussed, the OSDI and DEQ5 questionnaire. Then in the objective way, the most important thing is to evaluate the eye clinically in the slit lamp. You have to look at the lid margins, the conjunctiva, check the corneal sensation, how is the meibomian gland expressibility, tear meniscus, are there any debris over the interface, then tear breakup time and ocular surface staining. So when we express the meibum, if it is clear, it is healthy. When it is cloudy or inspissated, that is meibomian gland dysfunction. Then Oxford scale can be used to document these patients at every follow-up when you know that they have dry eye. These staining patterns can be used, and when you start the treatment for ocular surface disease, you start them on lubricants and all, you can see that if there is any improvement or not on your on starting the treatment. So treatment approach basically aims at minimizing the effect of the anti-glaucoma medication on ocular surface and recognizing and treating ocular surface disease as early as possible. So when a patient, like a normal patient who has been recently diagnosed with glaucoma, you should start with a single agent with a minimal possible dose, and routine lubrication is not required in these cases. So, and a patient who has a pre-existing glaucoma, first you have to ascertain the type of dry eye and then treat as per the dose to recommendation in a step ladder manner. So patients with pre-existing dry eye, so as I told that we have to reduce the concentration of BAK or shift to a BAK-free medication. So bimatoprost, that is available as in 0.01%, has a BAK of 0.02, can be shifted to bimatoprost 0.03, which has a BAK level of 0.005%. In a study where efficacy, safety, improved tolerability of travoprost back-free ophthalmic solution was compared with prior prostaglandin therapy, so it was seen that switching from a BAK-preserved latanoprost and bimatoprost to Sofzia-preserved travoprost was noted to improve ocular OSDI scores and decrease the conjunctival hyperemia and improve the visual acuity. There are n number of preservative-free medications available in the market as single-dose units or COMOD systems. Then preservative-free eye drops, the advantage is that they decrease the hyperemia, then blepharitis, superficial punctate keratitis, and fluorescein staining. We should also shift to combination treatment as it decreases the cumulative side effect of the back exposure. Then when we give the lubricants, all the 4 generation of lubricants can be given as frequent as possible. But to ponder upon is that polyethylene glycol and polypropylene glycol, they have HB-GOAR, which is pH sensitive. It undergoes cross-linking and gelling, as explained by Dr. Anu, that only at pH of 7.5. And these glaucoma medications, they work at a pH of 5.5 to 7.5. So they don't gel along well properly. So we have to consider not giving these type of drugs along with the anti-glaucoma medications. In lubricants also, they have the preservatives like BAC and polycord are there that can be shifted to oxidative type, that is stabilized oxychlorocomplex and sodium perborate. So there are n number of BAC alternatives or preservative medication BAC preservative-free purite, Sofzia, disodium EDTA. Then there is buffering of solution, ionic buffering of solution is being done so that the toxicity decreases. Then alternative treatment modality is available in cases which are who are tolerant to glaucoma medications, like glaucoma laser SLT, then microdiode trabeculoplasty. Then in mild to moderate cases, minimally invasive glaucoma procedure can be done with or without cataract surgery. And then in moderate to severe, like glaucoma filtering surgery or endoscopic cytophotocoagulation can be done. There are newer modalities that have come up, like introduction of new forms of drug delivery system, Novelia drug delivery system, then sustained release formulations allow for a depot release of glaucoma medication. Bimatoprost ocular insert, that is Durista, then latanoprost, travoprost punctal plugs, latanoprost eluting contact lenses, bimatoprost and travoprost intraocular implants. And like the take home message is being like dry eye and glaucoma are closely related, and we have to identify ocular surface disease early in these cases and treat them along with glaucoma. Then we have to opt for preservative free treatment or a combination treatment and keep medication to minimum to mitigate cumulative toxicity. We need to include regular ocular surface evaluation in treatment protocol, and this is significant concern and needs teamwork from all the subspecialties.